It's time to turn down the noise and tune in to News You Can Use, the show that gives you a quick insight into the latest twists and turns in healthcare news, where every diagnosis comes with an order of side-splitting humor. Your hosts are Dr. Nick, a longtime host, innovator, and healthcare wizard who can prescribe a digital dose of innovation to cure even the most ailing operational inefficiencies. And Dr. Craig Joseph, the healthcare guru who can diagnose both patient and software glitches with equal precision, making sure hospitals run smoother than a well-oiled robot doc. So buckle up, because we're diving into the ER of excitement, the ICU of irrationality, and the waiting room of wacky wisdom. Now here's Dr. Nick and Dr. Craig.
Welcome to the month of February. I'm Dr. Nick.
And I'm Dr. Craig.
This week, we will be dissecting the latest healthcare news, unraveling the twists and turns, and making sense of all of those debacles.
Just remember, life's a lot like a breaking news story. Unpredictable, often absurd, and occasionally leaves you just wondering if it's all just a cosmic prank.
So this week, we'll be taking a look at the Super Bowl and healthcare advertising.
And we dive into AI and its use in healthcare.
But first off, we have to talk the new CMS regulation on texting. Craig, are you texting and organizing your whole healthcare profession using the text message?
I do it when driving, Nick. I find it's more challenging that way, and I'm up for the challenge. No, I do not. I do not drive and text, nor do I recommend anyone do that.
No,
so
please do not. In fact, if you have an Apple iPhone, you can actually have it smartly say, Nick is driving, he can't respond, which I actually quite like. I use that all the time.
I know, it frustrates me so.
Yes, because of all those messages we exchange.
So no, I do not text my entire healthcare experience. Why do you ask, Nick?
Well, so CMS came out, and maybe it doesn't sound like a big deal, but they have essentially, as of the 8th of February, issued a notification on their policy that says they're now allowing hospitals and critical access hospitals the flexibility to include text orders via a secure platform that can be entered into the patient's medical record or the electronic health record. And that satisfies the need for an order, as it were, an order being, ordering a drug or a test or something else. And whilst that doesn't sound like a lot, that's a big step, because for the longest time, we, of course, went to the obvious choice here. Let's use the telephone because, gosh, there's no risk of any misunderstanding occurring when you're trying to tell somebody something over the telephone, whereas you could have texted it. No, we couldn't do that. Now we can. And there's been a lot of interest, a lot of excitement.
Yeah, I mean, there's also been some people who are concerned about it from a quality perspective. So, I mean, let's really just take a bigger look at this thing. So today, or in the past, if you might get a phone call from a nurse. They might actually call you directly, or just send you to your beeper. How's your beeper doing, Nick?
Oh yeah, my beeper. You mean my pager?
Yeah, that thing.
Yeah.
Yeah, you don't have that anymore, but a lot of doctors have that still. And you'd have to call them back, and they would say, "Hey, this is happening with your patient. Your patient has a fever, or their pain is out of control, and they probably need some more pain meds or something different." And you could give a verbal order under certain circumstances, right? And you could tell the nurse, order, change the medication to 10 milligrams instead of the current 5 milligrams, or order a lab test, or order an x-ray. And then they would, in the olden days, they would write that down, and they're supposed to read it back to you. The olden days, with the paper and the pen. And yeah. And the fax is current. Yeah, that's modern. Yeah. So they would write it down, and they're supposed to repeat it back to you, right? So it was called verbal with read back. So doctor, you want a CBC and a SED rate, and you want it drawn stat. And you're like, yes, that's what I just said. And then we had electronic health records come along, right? And so now the nurse is supposed to, on the phone, do that read back, but you're supposed to stay on the phone. And this is where it's a little tricky, right? Because sometimes when that nurse puts that order in, they get a pop-up. They get some kind of response from the electronic health record that says, oh, you want to start this medicine. Well, did you know the patient's allergic to this medicine or another medicine similar to the medicine you're starting? Or did you know that they just had this CBC, this blood test 2 hours ago or this morning? And are you sure you want to order another one? Maybe that one is good enough. And so if you're not still on the phone when that pop-up happens, when the nurse enters the order on your behalf into the computer, then how's the nurse supposed to respond to that new information?
Ooh, pick me. I've got an answer.
Dr. Nick, what's the answer?
She texts you back to say there's a pop-up.
Right. And that's my point, right? So today you're supposed to stay on the phone and until that order goes through. But so now it's apparently okay to text. And it's not just any texting, Dr. Nick, right? Yep. It says the word secure texting, which means not supposed to do it, not going to be able to do it over the phone. I'm sorry, over your regular texting, the same way you text your friends.
So I think you're correct here, but is that true? Haven't we gotten to the point where some of these text messaging are encrypted end to end, so potentially it could be considered secure? Or is there a step more in this?
Well, it's an interesting question. If you're using an iPhone and the person you're texting is using an iPhone, and both of you have whatever you're supposed to have set up,
it's easy. You both have blue messages.
Yeah. Oh, cool. You're cool. That's what I'm trying to say.
Right.
Then, yeah. But I suspect that most hospitals in the U.S. will say, no. You're still not supposed to do that. You're supposed to use this other app that we have for you, which may or may not be as convenient. Yet still, it's certainly going to bring a lot of joy to a lot of physicians to simply say, order a CBC, or up the dose of this medicine to whatever. And from an understanding viewpoint, like it's all right there, like it's right there. You can see it and you can go back and look at it if you weren't sure, as opposed to talking on the telephone. Like, wait, did he say 10 or did he say 20? It's right there, and you should be able to see it. So seems like a step in the right direction. The question is, will hospitals allow it? The fact that CMS says it's okay, Nick, does not necessarily mean that it's okay.
Wait a second. You're telling me that even though the government says it's okay, we might still have to fight to have that opportunity? That just doesn't seem right.
Do you have a fever, Dr. Nick? No, you're being sarcastic. I feel like you're being sarcastic. I know you are. Yes, that's right. The fact that one government regulator says that it's okay doesn't necessarily mean that it's okay from the perspective of the compliance officer at my hospital or the lawyer at my hospital, because there are other risks besides the government coming after you, right? One could imagine that there might be a malpractice lawsuit that's based on this. And if you could convince a jury that, well, if you wouldn't have texted, if you would have called, this would have been this bad outcome that happened that may or may not be related, wouldn't have happened. And so
too bad. That's all I can say. I mean, I accept the point, but let's face a little bit of reality. We are, last time I checked, in the 21st century, and technology has moved on. We ought to be able to communicate, and sure, needs to be secure, all of those things, and use the appropriate methodology. If you can get into the EMR and do it directly yourself, that's what you do. But if you can't, and this requires the input, hopefully we're not going to get too many folks jumping up and down. I mean, I see it in the right place, but I get the resistance. I just, not all of it.
hey, yeah, I'm in favor of it. I will come out in favor of it, and just because there's the burden on physicians is so great that anything that we can do to make their lives easier. Again, what I understand from the administration, from a chief medical officer or a lawyer, I get their perspective as well. Of hey, is this now a slippery slope? Because it actually is much better if you're at a computer for you to put that order in. And if you have your phone and you're not driving, it's actually better and you have an app that allows you to do it and does it in a usable way. It's probably better for you to put that order in yourself. That said, there's often times where you're in the middle of talking to a patient and just want to get that, you just need to respond right now. And a secure text is a reasonable way of going.
Right.
I do see the concern. That's all.
And just to be clear, I've heard the slippery slope. It's one of the many fallacies that is thrown up. Oh, well, it's HIPAA or slippery slope. This will lead to terrible things. Anyway, well, I think it's good news. I think it's opens up some new potential. It was certainly it got a lot of coverage. You and I probably saw a number of the sort of commentaries, both sides of that particular coin. But moving on, artificial intelligence. Boy, what an exciting time we live in. I cannot get over. You and I both have, experience with this. We've talked about it a lot. I mean, the potential for this technology to actually deliver value, to really sort of create, positive experience. But unfortunately, it has a negative connotation. And, this is everything from the application of it to actually deny care. And it's gotten so bad. It's interesting that same organization, CMS, has come out and said the Medicare Advantage insurers that are using AI and these algorithms to assist them in coverage determinations have to make sure that they aren't using it to just deny, which is what we've seen a number of times, right? And in fact, I think there's also the nefarious use. And I don't consider that necessarily nefarious. I mean, maybe it didn't start out I'm being charitable here, but I don't think it started out that way, but got twisted because of the incentives. But some of them are being used to sort of go after and, bill for things that didn't have, so actual fraud, which, shock horror, we're using technology to do it. The good with the bad, unfortunately. Thoughts?
Well, it's I think we have to think about artificial intelligence and technology in general as a tool, and it's a tool that can be used for good. It's a tool that can be used for bad. It's no different than a scalpel, which is just a knife, and you can certainly use a scalpel to save a life, but you can also use a scalpel or a knife to end a life, and so. Yeah, you should not be using advanced technology to figure out a way to, I don't want to say cheat, but I kind of want to say cheat, to bend the rules so that you can deny care or reasonably say you're denying care and not paying for it. And that's what CMS said to insurers that are enrolled in this particular kind of Medicare program, Medicare Advantage, to say, hey, if you want to leverage artificial intelligence and other tools to help your clinicians, I think it's mostly doctors and nurses, to make better decisions about approving appropriate care and denying care that you think is not appropriate, by all means, go for it. However, you cannot automate that to the point where there's no human involved. And also to the point where all you're doing is saying no, 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 no. And right, it's just a little convenient when that happens.
Yeah, isn't it? Well, there's this sort of vague thought in my mind: 110,000 denials in 2 months from one physician. I don't know.
Yeah, you remember this. This
felt like a very personal experience.
It sounds personal to you.
It was.
Yeah. Well, it's the same thing. When you see, again, I'm saying clinicians, doctors and nurses, typically, who we're talking about, and they reject 100 claims in the span of 10 seconds, and the only way that's possible is to select everyone on the
Select
screen
all.
and just say
Yep.
select all and no and deny. It's clear that person did not look at, did not consider any of the information available to them. They just wanted to say no. And why? Well, it's in the financial best interest of their employer to say no.
Yes. Unfortunately, it's aligning incentives with the appropriate behavior is how you get the right behavior. What about the billing? I mean, I could say I was a little bit surprised to find that we've got these scams going on with massive. Oh well, not surprised that was going on, but that technology was being used to sort of run this up. Interestingly, the counter to this is and this has been my point about cheating on physicians, where people are misbehaving. Use the statistical analysis. And what they essentially did was, well, we can see that there's all this misbehavior because we see this massive spike that is completely out of the context. And rather than punishing everybody with all of these approvals on the principle that the majority of people behave the right way and try and do the right thing, find these suspicious charges and then go after it. Now, I know the money's probably already disappeared. Maybe it was invested in crypto or something. I don't know what people do with all this stuff, but that seems like the better use of it.
Yeah, well, we switched to another issue, right? So the first issue was insurance companies leveraging AI, potentially, I think, leveraging AI for misdeeds. And in this case, it was someone going after one of the big insurance companies, which happens to be the United States government, right? Medicare, and charging the government for services that were never provided to patients. And who figured that out? Certainly not the government. There were researchers who had access to millions of claims data of individual claims. And they started poking around and found that, typically, I think the number I'm looking at was, typically urinary catheters, about 50,000 claims came for urinary catheters, which actually seems low to me. But overnight, with 1 year's time, that number went from 50,000 to 450,000. And these researchers went to the government and said, maybe you should look into this. Why are you paying for all of these things? What's happened in medicine to make all of these people need catheters that didn't need catheters before? And of course, the answer was nothing. That most of these were lies, and there was no one to check into it. And in fact, if you read the article or other articles about this, many Medicare enrollees complained and said, "Well, I've got this notification. They're not sending me a bill. No one's asking me for money, but they're sending me a notification that, or Medicare is sending me a notification that they paid for these catheters that I never got, nor do I need." And they complained, and yet nothing got done, which is astounding.
Well, let's pick out some good news there, that people are actually looking at this stuff and saying that, because I do that when I get these EOBs and go, wait, what the hell is that? But the other thing that's positive is at least this was just a billing issue rather than actually putting in the catheters, which, if you've done that as well, which we've got some evidence of that, unfortunately, but let's not dwell on that. But, good news. I think we saw some positive use. Since it is February, I don't know if this is true, but we should be talking Super Bowl, right? I mean, is it always in February? I'm not an expert here.
I don't follow American sports, Nick, but
no,
it's
really?
around this time. It's around I follow proper football, not American football.
So you actually know who won the African Cup of Nations on the same day that Super Bowl happened? It was a real upset.
I don't.
Yes, you do. Nigeria got beaten out 2-1 by Cote d'Ivoire. It was a heartbreaker right at the end, but the winning goal scored by a comeback individual who had cancer and had recovered and managed to get back into the final and scored the winning goal.
I love it when the plan comes together that way. Yeah. So I know a little bit about proper football, clearly, but nothing about American football. Yet I know who won the Super Bowl. And it
I actually
was
don't. I have to go look it up. I know it's terribly disappointing. Well, I couldn't get involved.
listen, Taylor worked hard all year, and
I couldn't even tell you which team she's part of either. So that's obviously her team won, did it?
she's not technically on the Kansas City
Oh, is she
Chiefs.
not in it?
She's not technically on the Kansas City Chiefs, but she brought them a lot of money. So I feel like she's kind of a team member.
Contributor, we call that. That's the contributor level.
Absolutely.
So anyway, Super Bowl. And there was some commentary by Dr. Jane. And I have to say, I concurred. This flood of healthcare advertising just really sort of, I had to ask, do we really need all of this money spent on adverts? Is that the best use of our healthcare dollars to decide to sort of blow about whatever it is? You had competing ads from various groups. There was, the cancer, and we see this a lot. Is this really a good use of our healthcare money that's already overspent?
Well, the administrators of these hospitals and healthcare systems think so, and so it's hard for us to assess. I totally get where the concerns are coming from. Hey, you just spent $9 million on a 30-second advertisement for the entire country, when in fact this hospital is
was my head exploding. But
yeah.
Go on.
It might be that it's an A hospital in a city in a state, or it could be some of them are bigger healthcare systems, and so they have hospitals in 3 or 4 states. But does it make sense for them to advertise on the Super Bowl? They think so. They think that advertisement, clearly they must think that advertisement will bring them more patients, or the kinds of patients that they're trying to attract. It's in the same way that, as Dr. Jane kind of talks about in her blog post, when you name a stadium or a field and you get naming rights, which is another thing that healthcare systems are doing a lot. Does that bring benefit to the patients? Wouldn't it be a better idea to build another building, or to lower your fees, or to do other things? There's no easy answer. I understand the concern, but it's a business, and no margin, no mission. And if they think that these things are going to help them get more patients, I think it's a reasonable thing to say, if my logo is on the jersey of the local soccer team, the MLS team, maybe that makes people think that I'm really good at sports medicine. The hospital, the healthcare system, we have very good sports medicine doctors. And so if that makes me think of them in a more positive light, then I'm more likely to go there. I mean, that's the rationale.
I get it. But here's a thought. What about taking that same sponsorship dollars, and I'll give a specific example, although in some respects it's a little bit irritating, because I talk about this sometimes, that I'm fed up seeing people in scrubs everywhere. But if you bought scrubs emblazoned with your logo, and let's say Fig scrubs, I'm going to use that brand. I hope I get it right. I know there's some super comfortable, whatever, they're expensive. Bought that for all of your staff and issued them, but put your logo branded all over it, so that, they walked around with this, because they do, but they shouldn't. That's a whole separate story. Well, buy them cars would be my next offer, and say, drive around in those cars that are.
I like where you're going with this.
But I'm sure you could do that with that $9 million, and still have money left over to up the salaries a little bit. That just seems like a better spend of money.
It's a marketing thing. So yeah, it's tough. There's no good answer. I wish there were a good answer. Can I choose B? I choose B.
No, I thought you were going to choose C, but okay.
Always B.
There is no other option. Well, we find ourselves at the end of another episode exploring healthcare's mysteries before they become your emergencies. Until next time, I'm Dr. Nick.
And I'm Dr. Craig.